Welcome to this explainer. Today, we are moving way beyond just memorizing those squiggly lines on an ECG. We are going to truly master the P wave. So instead of just basic pattern matching, we are diving deep into the actual physical mechanics of atrial depolarization. It is kind of like looking straight under the hood of the heart's electrical system.
You know, the P wave is that very first positive deflection you see on the trace. Clinically speaking, this tiny little bump is your direct window into the health of the atria. It literally represents the exact moment of atrial depolarization. Think of it as the starting gun for the heart's entire electrical cycle.
Here is our roadmap for today. We will start with the normal P wave, then move into analyzing lead V1. After that, we will tackle right and left atrial enlargement, and finally wrap up with biatrial and other abnormalities. Let's get right into it.
Section 1. The normal P wave, building the foundation. First things first, we need to establish the baseline rules for a healthy rhythm.
So the criteria for a healthy standard sinus P wave are actually remarkably strict. First up, you always want to look for a nice, smooth contour. The electrical axis normally sits right between 0 and positive 75 degrees. All that really means is that it stays upright in leads I and II, and, as you'd expect, predictably inverted in AVR. There is also a hard ceiling for amplitude. It has got to stay under 2.5 millimeters in the limb leads and under 1.5 millimeters in the precordial leads.
And then we have this absolutely critical cutoff value, 120 milliseconds. If you are looking at standard ECG paper, that is exactly 3 small squares. Think of this as your speed limit. If your P wave stretches wider than those 3 little squares, well, the electrical signal is dragging through the tissue, and that is an immediate red flag for an underlying structural issue.
Now, if we map this electrical flow directly to the physical heart, we can see that atrial depolarization doesn't just happen all at once. It is a precise sequence. Because the sinoatrial node lives over in the right atrium, that chamber actually fires first. This initial firing forms the first 1/3 of the P wave. Just fractions of a second later, the signal sweeps across into the left atrium. This left atrial activation basically overlaps with the right side, which completes the final third of the wave. That middle third right there, that is where both the right and left atrial forces are summating together. It is this perfectly timed, synchronized dance that gives us that cohesive, smooth shape we see in a healthy patient.
Moving on to Section 2, analyzing lead V1, a different perspective. Let's talk about why not all leads tell the exact same story.
Let's compare 2 really critical leads, lead I2 and lead V1. In lead I2, the wave is typically just a single monophasic bump. Why? Well, because both the right and left atrial forces are generally moving toward the positive electrode. Simple enough, right? But then look at lead V1. Because of where it specifically sits on the chest, right atrial forces move toward it, which gives us an initial positive deflection. But the left atrial forces are moving away from it, pulling the trace down into a negative deflection. So V1 naturally separates these 2 forces out, giving us this incredibly precise diagnostic window.
All right, Section 3, right atrial enlargement. Taller, not wider. Let's dig into what happens electrically when that chamber physically stretches out.
So in right atrial enlargement, the right atrium literally has more tissue to depolarize. That means that initial wave of electrical activity lasts longer. Because of this slight delay, its peak now falls directly on top of the left atrial peak. The 2 forces just stack on top of each other. What this does is produce a P wave that pushes significantly taller than our standard 2.5 millimeter limit. But, and this is key, notice that the overall width doesn't change at all. It stays squarely under that 120 millisecond speed limit.
When you are looking at a trace and you see these striking, tall, peaked waves, especially down in the inferior leads like lead 2, you are looking at something called P. pulmonale. This is a classic hallmark of pulmonary hypertension. Conditions like cor pulmonale actually force the right side of the heart to work on overdrive, and that physical strain results in the exact electrical stacking we were just talking about.
Section 4. Left atrial enlargement, dragging out the duration. Now let's flip it and look at the opposite anatomical issue.
Now let's watch how the timing shifts here. An enlarged left atrium means that the second part of the wave takes longer to complete. The overall height actually stays normal, but because the left atrium fires last, this delay drags the total duration well past our 120 millisecond limit. The right and left peaks essentially pull apart in time, which often creates this really distinct visible notch right near the top of the wave. If you spot this on a real trace, this broad, notched, kind of bifid pattern, it is classically called P. mitrale, and it gets its name from its most common culprit, which is mitral stenosis. As that mitral valve narrows, pressure inevitably backs up into the left atrium, causing it to dilate. Your surface ECG is capturing that physical distress perfectly, translating it into a prolonged electrical signature.
And guys, always check lead V1, like we mentioned earlier, because V1 naturally separates the right and left forces, and enlarged left atrium is going to cause that terminal negative portion to become visibly deeper and wider. Specifically, if you see that negative drop going more than 1 millimeter deep and stretching greater than 40 milliseconds wide, well, that is a highly specific, pretty much undeniable marker for left atrial pathology.
Finally, Section 5, Biatrial and Other Abnormalities, the full picture. Let's bring these combined pathologies into focus.
Bringing it all together like this in a single summary matrix just makes the pattern recognition so much simpler. Biatrial enlargement happens exactly when the criteria for both individual enlargements show up together. So in lead 2, the wave is both tall and broad, and in V1 you get this massive positive initial bump immediately followed by a massive negative drop. Honestly, if you can memorize this matrix, categorizing these structural changes becomes almost second nature.
But it is not just about sheer size. P waves also tell us exactly where a rhythm is originating from. For instance, if you spot inverted P waves in the inferior leads, you know right away the rhythm is not coming from the sinus node. A short PR interval under 120 milliseconds suggests a junctional origin, whereas a longer one usually points to an ectopic atrial focus. Oh, and if you happen to catch 3 or more completely distinct P wave shapes on the exact same trace, you are literally watching multiple ectopic pacemakers firing off all at once. That is your classic multifocal atrial rhythm.
So here is a question to leave you with. How will recognizing these specific P-wave morphology changes alter your next steps in patient care? Translating these tiny electrical shifts into actual anatomical causes lets you look directly at the physical structure of the heart. It tells you what the heart is signaling long before symptoms even begin. Thanks for joining this